I think where the future is headed is better personalization of therapy. I think is the best way to look at it. We've really approached myeloma with a kind of cookie cutter algorithm for almost everyone that everyone gets 3 to 4 drugs and then plus or minus transplant and then this and that in general maintenance continued until progression and relapse disease is continued until progression, meaning until the myeloma comes back.
Hello, everybody. Welcome to the Patient Connect podcast. I'll kick things off by introducing myself. I am Noose, the host with Patient Connect. We are the tech platform for the Multiple Myeloma Warriors group, where we have 10,000 people approximately in the group. We have 2,000 people almost on our Patient Connect map. And what we're trying to do is connect multiple myeloma patients to one another, to specialists like our guest today, and to researchers and other resources that can help them. The goal is to really optimize the multiple myeloma journey and help researchers improve medications and hopefully find a cure. So we talk to patients mostly, but now we're starting to talk to specialists
Mhm.
and other folks in the multiple myeloma ecosystem. So with that, I'm going to introduce Dr. Rahul Banerjee. Dr. Banerjee, would you like to introduce yourself?
Of course. Thank you for having me on this podcast news. Thank you all for listening. So my name is Rahul Banerjee. I'm an assistant professor of medicine at the Fred Hutchinson Cancer Center in Seattle, Washington. I specialize in multiple myeloma and other plasma cell disorders. Happy to talk about that. And also as well as CAR T therapy and bispecifics. So I'm happy to speak to immunotherapies as well and heavily involved with those. My research interests are primarily in multiple myeloma and the patient experience. So I think we have a lot of things that we can talk about here. I'm a member of the International Myeloma Working Group, so I do a lot of work around the world, trying to figure out how to standardize how myeloma is diagnosed, how it's treated, and so forth. And happy to be here.
Excellent, excellent. So maybe you could take us from the top of how you became involved in multiple myeloma research from sort of residency to practice to specialization and all and ultimately research.
Yeah, absolutely so. So, I think multiple myeloma, as many of you listening to this podcast are living and experiencing personally, is an interesting cancer. It's never good to have an interesting cancer, but it's good that patients are in remission for years and years, right? I tell patients that the average patient diagnosed today with myeloma can probably expect at least a decade of living, if not longer. Whereas 20 years ago, the prognosis used to be 2 or 3 years for myeloma. So we've come a very long way from there. But yet, as you alluded to, is not considered curable yet for the vast majority of patients that comes back and trying to figure out why that happens. So I think from a scientific perspective, I think it's really interesting. There's a lot of unmet need to figure out how to both, make myeloma treatments better, but it's important to remember that better is not always more treatment, because I'll talk about a lot of my research is actually kind of, once people are in remission, how do we dial things back to maintain quality of life? And to that point, the other interesting thing about multiple myeloma is that, the average age of diagnosis in the US is 69. So most people are in their 60s, 70s are diagnosed, and they have other medical issues often on top of this, and trying to figure out how, again, do we optimize the patient experience to maintain myeloma control without causing any other problems or minimizing other problems is a really active area of research of mine. So I think, as a trainee, I trained under Dr. Nina Shah, who is at University of California, San Francisco at UCSF. Dr. Tom Martin are there, all big names in the myeloma field who are very interested in this. And so I kind of took that and rolled with it. Prior to becoming an oncologist, I had an interest in quality improvement and patient safety. I actually did a chief residency specifically in that. And that's kind of where my research interests are not, I do phase 1 trials, obviously, first in human. I do the usual clinical trials to test out new medications. But because of my quality improvement, process improvement hat and training in the background, a lot of my research and interests are primarily around using the drugs we do have and trying to make them work better for our patients.
Excellent, excellent, great. And so let's talk about some of the recent research you had. I know you sent me a research study on DEX and dose intensity, which DEX is sort of a mainstay for most people's regimens. So maybe you can talk about that paper, and I'll link it in the description of this podcast as well, so people can follow along. But maybe talk about that and what's on the frontier for patients.
Yeah. Yeah, absolutely. So that was actually published. Yeah, we're doing this interview in January 2025. It was actually published officially today in Blood, which is the biggest hematology journal in the world, I would say. Thank you. I know it was a good collaborative
Yeah,
effort by a lot of us. I'm happy to have it there. But in brief, many of you who have had any sort of treatment for myeloma are familiar with dexamethasone. So, in talks that I've given to patients before about this, I said dexamethasone is the hero of the narrative until it becomes a villain of the narrative. Dexamethasone is a steroid, high dose steroid. It works very quickly. So many of you who have been on it know that, for example, in cases of patients who are in extremis, lots of bone pain, kidney damage, something happening, you need to move quickly. Dexamethasone is cheap. It can be given, it's a pill, it's easy to give. You can give it for 40 milligrams with 10 pills for 4 days. It works very well. Long term, though, that's where the toxicities start to build in. So a lot of my prior research, we know that dexamethasone has been around in myeloma treatments, but we haven't really talked about the long-term toxicities of it. And many of you are familiar with the dose-to-dose toxicities, right? Many of you who have been on dexamethasone know it makes people jittery. It makes them not able to sleep at night. It makes their blood sugars high. It makes their legs swell up. It can cause heartburn. The list goes on and on and on. What we did, we tried to look at some of these long-term side effects, even in patients who don't think the Dex is causing them problems. Is it causing problems? And in short, the answer is yes, it is. Some of our prior work, for example, was published in the American Journal of Hematology technically last year, 2025 now, used another group called Health Tree, another patient hub, and used their data. And we looked at the risk of cataracts. And we found that dexamethasone, the more that someone was on dexamethasone, the more their lifetime dose of dexamethasone, so not just milligrams per dose, but number of doses over months and years, their risk of cataracts went up. And we actually adjusted for age. So it's not just that patients who live longer are on more dex and get more cataracts. There's something specifically about dexamethasone that can cause cataract. That's a good example, right? Because, as people get older, vision is important and it's important to be able to drive. And if dexamethasone is not adding any benefit, but it's causing risks like that, even if you're not noticing that risk, that's a real risk. And so, after that study had gotten published, we thought about, well, what can we look at next? And so what we did was we looked at two very large phase three studies. Phase three studies are the largest kinds of studies we can run in cancer. One was called SWOG SO777, one was called SWOG S1211. And in brief, those are studies of newly diagnosed multiple myeloma. About 12 years ago now, 13, actually 15 years ago, Dr. Vincent Rajkumar, one of my mentors at Mayo Clinic, published a paper comparing Dex 40 milligram in pulses, so daily for 4 days, versus Dex 40 once a week in myeloma induction, meaning a newly diagnosed myeloma, trying to get people into remission. And they actually found that patients who got the Dex in high doses continuously, so 40 milligrams for back to back to back to back for 4 days, then 4 days off, then 4 days on, 4 days off, a lot of them actually were dying more of side effects. And so that study showed that Dex 40 milligrams once a week is kind of the best way to go. Again, outside of patients in extremis. For patients, once a response has been achieved, Dex 40 once per week is kind of the baseline there. What we looked at within studies using that type of regimen, Dex 40 to 60 milligrams once per week, was that necessary? Was even that dose necessary? There's never been a randomized trial of Dex 40 milligrams once a week versus Dex even lower doses once a week. So we tried to do a natural experiment. We looked at patients who were enrolled on these trials, and we looked at those who had maintained full dose dexamethasone versus those who had had a dexamethasone dropped, a dose either reduced or stopped for any reason during induction. These are patients on clinical trials. So not only are they healthier patients in general who are able to get to an academic center and be on a clinical trial, in general, clinical trials, they kind of set up guardrails. So I can't do everything that I would normally do. So in real life, for example, while I would very easily drop someone dexamethasone or adjust someone's dose, clinical trials, you all have to follow the same paradigm. So it's often tougher to adjust medications. Long story short, we found that over two-thirds of patients required dexamethasone dose reductions during induction, so that 40 to 60 milligrams once per week was not sustainable for them. More importantly, those patients who had dex dose reductions did just fine. Their progression-free survival, so how long that they were in remission for until the myeloma came back, and their overall survival, how long they lived, was identical, whether they had had the dex full dose for all of induction versus dex dose reduced during induction. The groups were otherwise pretty similar, the similar age distribution, similar myeloma distributions, and so forth. So it's not exactly the same as a randomized study because we weren't randomly assigning patients here, but they were pretty balanced in terms of how they behaved. So that helped us see that perhaps in these patients, you don't need to maintain dexamethasone full dose for all 6 months of induction. There was a previous study by Dr. LaRocca and colleagues published in Blood a couple years ago that looked at RD, which is a doublet, just Rev Dex. In the US, we don't typically use Rev Dex anymore. So lenalidomide and Dex, or Revlimid plus Dex. And they compared either keeping the dexamethasone on until progression, so keeping it on for years and years, or stopping after 9 months. And a similar conclusion. Actually, there was a trend towards the group that stopped the dex after 9 months actually living longer. It wasn't quite statistically significant, but there was a little bit of difference you can look at and say something's happening here. And most recently, just last month at the 2024 ASH meeting, American Society of Hematology, there was a big study presented by the French group, the IFM 2017-03 study by Dr. Monnier and colleagues, looking at dex-sparing regimen. So it's sort of so what basic randomized patients to either get Rev-Dex versus Dara-Rev, Dara, daratumumab, or Darzalex, where the dex was stopped after 2 months. And again, the Dara-Rev group did amazingly better compared to the Rev-Dex. What do you mean with all these put together with our paper and these other two? One hasn't been published, but our published paper, the other published paper also in Blood, and this new one that will be published somewhere soon. In brief, dexamethasone is likely dispensable after time. I'm not saying that nobody should ever be on dexamethasone, but especially during the first cycle of any new treatment regimen. I think it's a very powerful drug to have on board. Many of you have noticed its benefits, right? So it can absolutely help with bone pain, for example. It can bring the myeloma numbers down by itself. Doesn't last forever, but it does work as has some myeloma properties. For modern medications like daratumumab, which is Darzalex Faspro, or isatuximab, which is Sarclisa, the dex can also help to prevent allergic reactions or infusion injection reactions with the medication. But in general, you should not stay on it forever. So my approach, and we're actually working on a publication about this now, is that, for most patients, after 1 to 2 months, the dexamethasone should be either tapered down to zero or at least down to a lower dose or just stopped entirely for most patients. In the relapse refractory setting, when the myelomas come back, once they've achieved the response, the dex should also be dropped. The idea is that dex is very helpful in the beginning, but after a couple of cycles, after a couple of months, it's not adding that many benefits. And we have studies showing from my work and others that it does cause risks long term, like bone health issues, muscle issues, the cataracts I mentioned. So it makes sense to drop it. Easy for me to say this, but it's most patients love this, right? They love dropping the dexamethasone, and part of the reason we have to study this so rigorously is because I can see why people get nervous, right? Dexamethasone has been around for over 40 years in myeloma. It used to be the only drug we had in myeloma that worked properly were steroids, and so we've kind of constantly been adding new medications on top of it. So the Revlimid got added to the Dex, the Velcade got added to the Revlimid, the Dara got added to all of that. We haven't really gone back and fixed the underlying core to see if it's still necessary anymore. And so that's a lot of my research showing that that can be done. And I would argue that 5 years from now, my goal is that for all clinical trials going forward, to plan to stop the DEX after 1 to 2 cycles, exactly as I'm envisioning. For those of you listening to this who are on dexamethasone and don't want to be, I would say talk with your doctor about it. I'm not faulting, community-based oncologists. A lot of times they're playing by the rules. Because again, the clinical trials, they just build and build and build on top of the old one. So clinical trials did include dexamethasone by the book, 40 milligrams once a week until progression, often several years worth of dexamethasone. In real life, the myeloma specialists are no longer doing that, and they're just trying to help spread that and put that into the trials, into the guidelines, so that it's available to everyone in the US.
Awesome. I mean, that's really groundbreaking research, and I think that'll help patient outcome and quality of life,
Absolutely.
particularly, right? So, which is what we're all about here. Um, so, in terms of like, traditional delivery of care in other places, how does Fred Hutch sort of stand out, and how do you guys think about care differently?
Yeah. So I mean, obviously I'm biased because I work here, but I do like it. I'm privileged to work with so many great colleagues, so many wonderful patients. Some of you may be listening to this at some time. It's so high. I think what two things a little bit Fred Hutch Cancer Center. So the Fred Hutch Cancer Center. So one, I think, is that we are very good at delivering cancer care. One example that I'll give is that we have a dedicated cohort of schedulers. We call them patient care coordinators who work with me, and they're wonderful. I remember at other centers where I've worked, as many of you know, this idea of time toxicity with myeloma treatment is very, very real. The idea is that if you need a PET scan or some sort of scan, you have to call yourself to schedule it. It may not be the same day as your, bortezomib injection, and so you're coming on 2 different days, or you have scheduling toxicity where you're kind of stuck, on the phone waiting to call and waiting to get a call back to schedule an appointment. Here, we have a team of schedulers who can schedule everything on the fly easily and reshuffle dates to kind of make things work for you. That I think is the easiest reason to choose kind of Fred Hutch, the model here that we give. I think I like that we're all myeloma specialists. So again, all I do is multiple myeloma and other related disorders like AL amyloidosis. The nurse I work with, she also does only multiple myeloma. The scheduler I work with, only multiple myeloma. Same for the pharmacist. And especially with these things that I'm alluding to, where it's unfortunate that, myeloma treatment is advancing so quickly that, as I alluded to, the trials are doing one thing, but we in real life as myeloma specialists have learned that this slight tweak is actually better for patients, but it hasn't yet been published. And so I think, being at a center where, all we do is myeloma is very helpful. And that's an important reason. I think, especially in me, Fred has been very supportive of my research around, you know, time toxicity I alluded to, how much time people spend in clinic. So another big paper we published last year, for example, showed that once per week bortezomib works just as well as twice per week. So once weekly Velcade, as opposed to days 1, 4, 8, 11, which is Monday, Thursday, works just fine. That kind of research is not, again, it's not a phase one new drug. It's just what we already have. Fred has been very supportive of that. We have trials open here, for example, of prehabilitation. So, exercise programs to help people be stronger. We have a life coach. We have two life coaching studies open where patients who participate are paired with a life coach that they can talk to by phone call, text message, email to work on whatever they want to work on. For some people, that's sleep. For some, it's anxiety. For some, it's just about eating healthy, living healthily, and so forth. And so we have a lot of tools like that, and Farhad is very supportive of that, and we have those trials open. So that's what I would say, are what I like about my job here. What I would say is, honestly, only about half of my patients are truly my own, where I'm the one doing all of their management. Honestly, probably more than half of my patients are primarily followed by my colleagues in the community who are wonderful because they know the area, they're much closer to patients. Some of my patients have more than one kind of cancer, and then in that case, the community oncologist is way better than me because all I do is myeloma. But I can see those patients every 6 months, once a year by Zoom, like by telemedicine, basically, just to check in and see how you're doing. Let's talk about next steps like CAR T therapy if the myeloma comes back, etc. And so I found that that's a very helpful middle ground for patients who don't want to travel to a city like Seattle, but want to get some myeloma expertise on board. I would say you don't have to choose oncologists. We play nicely in the sandbox with each other. I'm very happy to work with colleagues across really the country. I have patients who are followed in Alaska, Hawaii, Oregon, Idaho, Montana, all over the place. I have some patients who are in Washington for the summers and then California or Florida for the winter, and we figure out a plan to have them go back and forth between two different myeloma specialists. So I would say, I love Fred Hutch's motto, and then if any of you are listening to this and are interested, definitely we're happy to see patients, happy to comment on things, especially again mainly around these tweaks. Again, how the difference between what the trials did when they were published versus what we do now. We're very happy to help educate you about that process, but more importantly, educate your primary oncologist about that to make sure that they're doing everything they can to maximize your quality of life and your length of remission.
That's fantastic. And can you talk about those tweaks and sort of how researchers and providers can better collaborate, in terms of like not everybody's going to be able to come to Fred Hutch, right? So just, centers of excellence where research is being done, how do you think that dynamic between that research and actual, real life, those feedback loops become shorter?
Yeah, so there's two ways to answer that question. So one, I would say we do a lot of real world data. So that paper I mentioned about Velcade bortezomib, that was real world data through Flatiron, where basically that includes a lot of community-based practices. So I would say that even if you're just doing what you're doing, we're able to use real world data. The idea of real world data, as you're alluding to, is not patients who are carefully selected, able to go into clinical trials. If we're meeting patients where they are looking at their data, it's not perfect, obviously. With a clinical trial, we're able to really randomly assign who gets what. With real world data, there's some messiness inherent to it or missing data inherent to it. People move back and forth between centers, totally fine. So I would say that we're still able to use data and learn from our partners and patient colleagues no matter what. The second answer I would give is that, again, probably resources like this, like what Polygon Health has, I worked with HealthTree before many times, and that's a good example where, that cataract paper I mentioned, that came from HealthTree. So the data and the patients who very kindly volunteered their linkage, they linked their EMR, their MyChart, their medical records with the HealthTree account. We were able to go back and actually look and query their cataracts and how many milligrams of dexamethasone they'd received. And so we use that for data. So I would say those kinds of decentralized platforms are very helpful. And then the third thing I would say is the biggest as you're kind of alluding to, I can publish all this amazing research. We're doing a prospective trial now where we actually are dropping the decks after 2 months, for example, just to show that it's not just a random, not just looking in hindsight, truly going forward, this is how we'll do it, this is how the future will look. Easy for me to do that, but it's how will people see those studies in the community? And so I would say the biggest thing that all of you can do is just, as you're probably doing already, is advocate for yourself. Always ask for a second opinion, use these resources, other resources to learn about new options available for you, the clinical trials, CAR T, etc. Happy to meet with one of us. And whenever I meet with a patient who's not mine, I always follow up with the primary oncologist religiously every single time to make sure they understand why I'm saying what I'm saying and why I would tweak what they're doing if there are any tweaks to be made. And so I think that advocacy will be helpful because I think it's hard. Myeloma was already very confusing. I'll openly admit that for doctors now. Myeloma is one of the most confusing cancers to have because there's so many treatment options. The trials aren't all being compared to each other. It's very difficult unless you're a myeloma specialist like me to be able to tell what's what and what actually makes the most sense. And so I think spreading that, like allowing you as a patient to see both a myeloma specialist and a community doc actually might help not just your care, but actually might help future patients because I'm able to tell the community oncologist, here's what we've learned, here's what we do. And it's a great two-way street, right? Because then they also send me patients. I sometimes send them patients. They know the resources in the area. Like I have patients who are in Idaho, Montana, Hawaii, for example. Their primary oncologists are way more useful than I am to actually figure out what the resources are there to support patients and grants and so forth. So it's again, we play nicely together as physicians, but only if we know each other's phone numbers and are able to reach out.
Right. Oh, thank you for answering that even more proactively because I was just going to ask about patient advocacy, but I think you answered
Mhm.
that, and that's great advice to, patients and caregivers. Um, in closing, right, where do you see sort of myeloma research going over the next, 5, 10 years? And, how can listeners better connect into this type of research and follow along?
That's a great question. So I think where the future is headed is better personalization of therapy. I think is the best way to look at it. We've really approached myeloma with a kind of cookie cutter algorithm for almost everyone that everyone gets 3 to 4 drugs and then plus or minus transplant and then this and that. In general, maintenance continued until progression and relapse disease is continued until progression, meaning until the myeloma comes back. And so I think the biggest new cool thing in myeloma is MRD, measurable residual disease. It used to be called vanilla residual disease, right? And you're nodding, right? Many of you will have heard this before. The idea is that with MRD, you can pick out 1 in a million myeloma cells hiding underneath the surface. There's two left in the country that can do MRD. One is, really two. There's maybe more than two, but one is the Mayo Clinic in Rochester, and one is half a door down here in Seattle, Adaptive ClonoSeq. And they're great. And I think the promise of MRD is that it can allow us a personalized treatment. We're participating in the Master 2 trial right now, which is actually taking that unified timeline that everyone newly diagnosed gets Dara VRD, transplant, and then Len or Dara Len maintenance, and we're actually having them randomized based on MRD status. For patients who achieve MRD negativity, we're randomizing them to randomly assigning them to either get the transplant or not get the transplant. Because we really don't know if transplant has benefit if someone's MRD negative. For patients who are MRD positive who don't achieve MRD negativity, that's okay. But we don't know, is conventional therapy good for them, or should we try to one up it? Should we augment the maintenance with a newer medication called teclistamab to kind of help keep them in remission for longer? So I think that's where the studies are headed, where instead of just basing everything about our treatment decisions based on someone's age and the set of genetics, how the myeloma cells look at diagnosis, and never again personalizing care, going back and looking at MRD dynamically and saying, all right, if you achieve MRD here, we do this. If you don't, we do this, and so forth. In terms of how patients can dial into this, I think these communities are helpful. I would say if you want to, hear what the myeloma specialist community is thinking, so two resources. One, obviously these kinds of interviews, but also, for example, the International Myeloma Foundation, IMF, did a lot of talks where myeloma specialists, and I've done these talks before, kind of talk to the regional community workshops, talking to people in the area about updates in myeloma. I think those are pretty helpful to hear from myeloma specialists and often myeloma specialists who are not from your area, right? Because I am not infallible by any means. And a lot of times I hear that, oh, my colleagues in Texas are doing things this way and they've had better results than we have. So let's change things around, right? So it's great for everybody. The other, I would argue, if you're interested, not for everybody, is Twitter. The platform that people sometimes call X now. We've been using it for years, well before that takeover, and it's helpful. A lot of the myeloma specialists are on Twitter. I am on Twitter, quite active on it, and I think it's a very helpful tool to hear what we're thinking, because that's how I find about new articles, and I try to, summarize them in plain English, hear from other researchers and so forth. And you'd be surprised that there are a lot of patient advocates on Twitter. I work with them. I've sometimes collaborated with them on research studies, and obviously their perspective is different than that of a myeloma physician. They don't have this whole MD to their name, but I would argue that their perspective is more real, right? Because they're the ones who are actually on the business end of what we're talking about here. And so I think it's really helpful to see that those kind of collaborations grow and conversations grow on Twitter. So I would say that might be one way to kind of just hear about what's changed, what new studies are out there, what people are thinking about, especially to learn the language of MRD and quadruplet and CAR T and so forth.
Beautiful. Let's wrap it there. Dr. Banerjee, this was incredible. We really appreciate the impact of the work that you're doing, and congrats on getting your paper into Blood, of course. And I know we will stay connected as we grow this community and we do make this type of research more accessible and thought leaders such as yourself more accessible. So appreciate you doing this and more to come in the future.
Absolutely. Thank you all again. And I don't know when this will go live, but Happy New Year if it goes live in this month of January 2025. If not, looking forward to seeing many of you on some other talk or in clinic somewhere else later. Thanks all.
Absolutely. Thank you.
Yep.